All right, let's talk about the initial management of type 2 diabetes. What we're going to build today is a mental model, a high-yield framework that you can apply to pretty much any new patient who walks through the door. This isn't just about memorizing drugs, it's about having a clear strategy. So let's dive in.
We're going to break this down into 4 simple steps. First, we have to know our goal. What are we even aiming for? Then we'll lay down the foundation with metformin. After that comes the really interesting part, the fork in the road, where comorbidities tell us where to go next. And finally, we'll cover the big exceptions, the red flags that tell you to go straight to insulin.
So before you write a single prescription, you have to ask yourself, what is my target? The very first step always is to set a clear and, really importantly, an individualized glycemic goal for your patient. Now, for most non-pregnant adults with type 2 diabetes, that goal is going to be an A1C of less than 7%. So why that number? Well, it's really the sweet spot. It's where the evidence shows we get a major reduction in the risk of microvascular complications. Damage to the eyes, kidneys, and nerves, without pushing the risk of hypoglycemia way too high.
But, and this is absolutely crucial, one size does not fit all. You have to tailor the goal to the person in front of you. Think about your young, newly diagnosed, otherwise healthy patient. For them, you might push for tighter control, maybe less than 6.5%, to give them the best long-term outcome. But now flip that. For your frail, older patient with a bunch of other health problems or a history of bad hypoglycemia, pushing that hard would be dangerous. For them, a looser target, maybe less than 8%, is much, much safer.
Okay, so we have our target. Now let's start building the treatment plan. And the foundation, the very first block we laid down for almost every single patient, is metformin.
Metformin, plus of course comprehensive lifestyle changes, is the absolute cornerstone of therapy. This is our preferred first-line agent, and for some very, very good reasons.
So why is metformin the king of the hill? Well, first off, it just works. It's got high efficacy, dropping that A1C by a solid 1 to 2%. It's either weight neutral or can even help with some modest weight loss, which is a huge win. On its own, it doesn't cause hypoglycemia. Plus, it's been around forever, we know it's safe from a cardiovascular standpoint, and it's incredibly cheap. It just checks all the boxes.
Of course, no drug is perfect. You're going to see some GI side effects, mainly diarrhea and nausea. The trick there is to start low and go slow with the dose. And if someone's on it for years, keep an eye out for B12 deficiency. But the one thing you absolutely cannot miss, the hard stop, is renal function. Metformin is contraindicated if the eGFR is less than 30 because of the risk of lactic acidosis.
Okay, so your patient is on metformin, they're working on their lifestyle. Now what? This is where we hit the most important decision point in all of modern diabetes care. The path forward from here isn't just about the A1C anymore, it's all about the patient's other health problems. This is the fork in the road, and this is the critical question you have to ask. Does this patient have established atherosclerotic cardiovascular disease, heart failure, or chronic kidney disease? The answer, yes or no, completely changes what you do next.
And this, right here, is the paradigm shift. If the answer is yes, if they have ASCVD, heart failure, or CKD, our goal is no longer just about lowering sugar. It's about protecting their organs. We need to add a second agent specifically for cardiorenal protection. That means adding either an SGLT2 inhibitor or a GLP-1 receptor agonist. And get this, you add these drugs even if their A1C is already at goal. It's a game changer. So, how do you choose between the two? Well, you let the specific comorbidity guide you. If your patient's main issue is heart failure, especially with reduced ejection fraction, or they have chronic kidney disease with protein in their urine, you're going to lean heavily towards an SGLT2 inhibitor. If, on the other hand, the big issue is established ASCVD, or if significant weight loss is a top priority, a GLP-1 agonist is a fantastic choice.
But what if your patient is on that other path? What if they don't have any of those major comorbidities? Well, then our decision for that second agent becomes about other factors. We start asking, how important is weight loss? How critical is it that we avoid hypoglycemia? And what about cost and access? These are the things that will guide your choice of what to add next.
So far, we've got a nice, clean algorithm. But there are times when you need to throw that initial playbook right out the window. There are some serious red flags that tell you to skip all the oral meds and go straight to insulin.
Red flag number 1, a sky-high A1C, greater than 10%. When you see a number that high, it's a sign of severe insulin deficiency. The body is just overwhelmed by what we call glucotoxicity.
Red flag number 2 is along the same lines. a blood sugar that's consistently at or above 300. At this point, oral medications are just not going to be powerful enough to bring things back under control.
And our third and maybe most important red flag is seeing signs of catabolism. This means the body is so starved for insulin that it can't use sugar for fuel, so it starts breaking down its own muscle and fat. You'll see this as unintentional weight loss. All that sugar also spills into the urine, dragging water with it. That's polyuria, or peeing all the time. And of course, that leads to dehydration and intense thirst, which is polydipsia.
So if you see any of these, a really high A1C, really high blood sugars, or those catabolic symptoms, your next move is simple and immediate. Start insulin. Period. We need to give the body the insulin it's screaming for to break that toxic cycle and get the patient safe.
So we can really boil this whole strategy down to a simple 3-step rule. 1. Start with the foundation, metformin plus lifestyle. 2. Assess for those high-risk comorbidities. If they have ASCVD, heart failure, or CKD, you add an SGLT2 inhibitor or a GLP-1 agonist for organ protection. And 3. Always look for the exception. If you see severe hyperglycemia or signs of catabolism, you go straight to insulin.
And there you have it. That's the core framework for getting started. But it naturally leads to the next big question, right? You've done all this, you've started therapy, but 3 months later, that A1C is still not where you want it to be. So what's your next move? And that's where we get into the whole world of treatment intensification.